Good morning, everyone. My name is David Shurtleff. I'm the Deputy Director for the National Center for Complementary and Integrative Health. And it's my great pleasure to introduce our final speaker of our 2016 NCCIH Integrative Medicine Lecture Series, Dr. Roger Chou. Dr. Chou is Professor of Medicine in the Department of Medicine and of Medical Informatics and Clinical Epidemiology at Oregon Health and Science University School of Medicine. He's also the director of the Pacific Northwest Evidence-Based Practice Center. And Dr. Chou's research is quite timely given the current opiate epidemic, and if you've read the Washington Post this weekend, even more information about some of the use of opiates and how the industry is really doubling down on use of opiates for treatment of chronic pain. So Dr. Chou's research focused on approaches for evaluating and managing pain, including low back pain, postoperative pain, and the use of opiates, diagnostic test evaluation, and disease screening and prevention that has resulted in systematic reviews and clinical guidelines. In fact, Dr. Chou led the development of the guidelines for the use of opioids for chronic pain for the American Pain Society and the American Academy of Pain Medicine. And most recently was co-author of the Center for Disease Control and Prevention's 2016 guidelines on opiates for chronic pain. His work has resulted in over 110 original research reports, clinical guidelines, and book chapters combined. In addition, he serves on the editorial boards of the Journal of Pain, the Spine Journal, and the Journal of Applied Biobehavioral Research. Today, Dr. Chou will discuss the epidemiological data on opioid prescribing, the evidence on benefits and harms of opioid therapies, and the CDC guidelines on opiates, including their implications for clinical practice. So please welcome Dr. Roger Chou.
Good morning. Thanks for having me here. It's great to be here to talk about this very important public health issue. Just a quick conflict of interest disclosure. My funding has been from AHRQ, the American Pain Society, and CDC, no pharmaceutical or device company funding. So the goals for today will be to address several areas. First, just to get some grounding in terms of opioid prescribing patterns and the epidemiology of the issue. Then looking at the evidence on risks and benefits of long-term opioid therapy. Then we'll review the recommendations for safer opioid prescribing based on the recent CDC guideline, understand some of the policy and practice implications for this. As you all know, chronic non-cancer pain is highly prevalent and results in substantial burdens. Estimates of chronic pain vary depending on the population you're looking at, as well as the definitions used for chronic pain. But some estimates are that up to 1/3 of American adults report some chronic non-cancer pain. Opioids have become increasingly prescribed for this problem. About 5% of adults in the United States reported use of long-term opioid therapy in one large health insurance system. And what we do in the United States is quite different from pretty much anywhere else in the world. We account for about 5% of the world's population. We use about 80% of the world's opioids, 99% of hydrocodone, which is the #1 prescribed drug in the United States and has been for many years. Like other drugs, opioids are associated with potential harms, but they're unique in that the harms aren't just related to the patient. We also have societal harms, and we'll talk about those in this presentation. This is a slide that many of you have probably seen before. This is from the CDC, and Mark Sullivan at UW, I borrowed this from him. He made some modifications to it. But it shows that over about a 10-year period, sales of opioids quadrupled. And what you see is that in parallel, the numbers of deaths increased about 4-fold, and then a number of cases of treatment for opioid use disorder also increased in parallel. The statistic that many people cite is that since 2008, we've had about 15,000 deaths related to prescription opioids per year. This exceeds the number of motor vehicle accident deaths in most states now. This is the first time, in fact, that something has exceeded motor vehicle accidents as the most common cause of accidental deaths in the United States. This, I think, illustrates some of the societal implications. If you focus on the right side there, this is adolescents, so kids 12 to 17 years old, so junior high, high school. And about 7 to 8% of them say that they've used a pain medication that wasn't prescribed for them in the last year. So often getting it from the medicine cabinet or from a friend or other family member. I think this is quite worrisome. This is about 1 out of every 12 junior high and high school kids. You don't see this with other medications, right? People don't go into the medicine cabinet and use, mom's metoprolol or whatever. If you get to seniors in high school, it gets up to about 9%, and then young adults, it's even higher. So college age and slightly higher, it's about 12%, so 1 out of every 8. And this is, again, important in terms of its societal ramifications. These are some of the trends that we've seen in terms of opioid overdose deaths. Since 2000, we've seen a steady rise in deaths related to opioid analgesics that have kind of leveled off over the last few years, but are still much higher than baseline, about 4 times higher than at baseline. Heroin deaths had been pretty steady and then just started bumping up over the last 3 or 4 years. And this slide might kind of explain what we're seeing there as well. So if you look back to the 1960s and if you asked heroin users what their first opioid of abuse was, it was heroin. It was a street drug. So the vast majority of people who use heroin were first exposed, using illicit drugs. That trend has completely reversed now. So whereas most people who use heroin now were actually first exposed to an opioid through a prescription. So again, some of the societal ramifications and impacts of these drugs, which make them quite unique. Just some basic stuff on opioid pharmacology. Opioids work on mu receptors. These mu receptors mediate both the analgesic effects of opioids as well as the adverse effects, including the respiratory depression, GI effects, etc. We have agonists, partial agonists, things like buprenorphine, antagonists, things like naltrexone, naloxone. We also can think about opioids as natural opioids. These are the ones derived from the opium poppy, semi-synthetic opioids, and then synthetic opioids, things like methadone, fentanyl. This has relevance in terms of looking at metabolic pathways, etc. The half-life for most of these opioids is 2 to 4 hours. One outlier is methadone, which has a much longer half-life, 15 to 30 hours. It's also variable and unpredictable, which explains some of the issues that we'll talk about with methadone later on. One of the unique features about opioids is that ongoing exposure causes tolerance. This means that larger doses are required to maintain the original effects, both the analgesic as well as the adverse effects. There is inter-individual variability in the development of tolerance in terms of how quickly it occurs, etc. But we think this is a pretty universal phenomenon, that if you expose somebody continuously to opioids, you will get tolerance. This is a quote from Chou and Teresi. There appears to be no limit to the development of tolerance, and with appropriate dose adjustments, patients can continue to obtain pain relief. So this has led to our clinical practice of prescribing opioids with no dose ceiling. So this is another unique thing about opioids. Most medications, there are very few other medications actually that I can think of where there's no theoretical dose ceiling. You don't keep cranking up the metoprolol if somebody's blood pressure doesn't get controlled. But that is what we have done with opioids. This slide just illustrates the dose-response relationship for respiratory depression. On the left is fentanyl, so this is a pure opioid agonist, and you can see as the dose goes up, ventilation goes down, and this is, you're not breathing and need to have artificial ventilation. Whereas for this slide, this is buprenorphine, which acts as an opioid agonist at lower doses and then acts as an antagonist at higher doses. So this is the partial agonist effects. And so we think that the respiratory effects of buprenorphine actually plateau. And again, this slide just illustrates how some of the pharmacological properties of the different opioids differ. So I think it's worth kind of stepping back and thinking thinking about how did we get to the situation that we're in now where these medications are so widely used and we've started to run into so many issues with them. I think there have been a variety of factors that have contributed to this situation. One is that there was a perceived undertreatment of chronic pain. This was viewed as a deficit in terms of how we were prescribing, why were we withholding potentially effective drugs from people who are suffering. And laws and regulations were passed in over 20 states actually making use of opioids for chronic pain permitted. There was a low risk of abuse observed with use of opioids in palliative care settings. This was kind of transferred over to the chronic pain world. This is a quote from Russ Portnoy. Patients rarely demonstrate euphoric responses to opioid drugs, and neither analgesic tolerance nor physical dependence is a significant clinical problem. So we took our experience in the palliative care setting and basically, said, why can't we apply this to people with chronic pain? There were also some case series describing the benefits of long-term opioid therapy for chronic pain that reported low rates of abuse, addiction, and other serious adverse events. Most prescribed low doses, less than 20 milligram morphine equivalent doses per day. As you'll see on the next slide, some of the details were very limited in some of these early reports, yet they've been widely used to kind of support our practices. As I mentioned before, there was no ceiling dose used in palliative care settings. Oftentimes we would titrate these medications to quite high doses actually to achieve pain relief for cancer patients, etc. And again, this was transferred over to the chronic pain world, and this is another quote from Russ Portnoy. Escalation of the opioid dose until either adequate analgesia occurs or intolerable and unmanageable side effects supervene as standard practice in cancer pain management and became kind of standard practice in non-cancer pain management. We also saw an emphasis on round-the-clock dosing using sustained-release formulations. This coincided with the release of new formulations of sustained-release opioids, for example, sustained-release oxycodone and sustained-release morphine. Those were accompanied by unprecedented marketing pushes, campaigns for those medications. When you think about it, what are we doing when we're doing round-the-clock dosing with these medications is we're inducing tolerance and probably contributing to some of the dose escalations and other issues that we were seeing. So a lot of factors, I think, all came together to contribute to this. This is a paper that's often cited to support, that was often cited to support use of opioids in chronic non-cancer pain settings. This is a paper by Porter and Jick. It's actually just a letter to the editor. It's one paragraph, literally. Something, less than 100 words, I think. It's been cited almost 1,000 times now. They basically say the risk of it. So when people say the risk of addiction is much less than 1%, a lot of it came from this paper, which was, really a study of the Boston University database. They didn't have a lot of other information on there other than what was available in the database. They said there were only 4 cases of reasonably well-documented addiction. Retrospective, etc. So this was, a lot of the justification, or has been cited widely as one of the reasons for using opioids in the settings that we do. So the background for the CDC guideline: the CDC saw the need to address prescription opioid prescribing as a public health problem, given the marked increases that we've seen in overdoses and opioid use disorder. There are guidelines that have been developed by several states and agencies, but they have inconsistencies in the methods as well as the recommendations. The national guidelines, like the American Pain Society guideline that I work on, they're about 7 or 8 years old now. They don't incorporate the most recent evidence. Clinicians continue to report uncertainty about how to prescribe opioids and express a desire for clear and consistent guidance. The primary audience for the guideline was primary care providers. The CDC saw this as the group that's prescribing the most and also the group that expresses the most discomfort. Target populations was adults with chronic pain, so we weren't trying to address patients undergoing active treatment for cancer, palliative care, end-of-life care, etc. The guideline went through an extensive development process. We won't go through this in detail, just to show that there was a systematic review that we led at the Pacific Northwest Evidence-Based Practice Center. the CDC developed some draft recommendations. They convened an expert group. It underwent a lot of stakeholder, federal government review, and eventually was published in March. It's available open access on MMWR, and then a summary version in JAMA. The evidence review originally, this is an ARC-sponsored review that was conducted for an NIH Pathways to Prevention workshop. The CDC commissioned an update of the review in 2015, which we also conducted. We looked for evidence on effectiveness and comparative effectiveness of long-term use of opioids, and we were really looking for outcomes at 1 year or later, given that most people, once they're prescribed these medications for several months, actually will be on them for many years. We also looked for data on harms and adverse events, dosing strategies, for example, round-the-clock versus PRN dosing, risk mitigation strategies, including things like urine drug testing, PDMP checks, etc. The CDC asked us also to address effects of opioid use for acute pain on long-term use. This was felt to be one of the pathways that people get onto long-term opioids, and trying to understand how the ways that we manage acute pain may impact long-term patterns. So this slide summarizes the systematic review findings. Unfortunately, data were quite limited for many of the key questions. We found no trial that evaluated long-term, meaning greater than or equal to 1 year outcomes for pain and function. Most of the placebo-controlled trials were less than 6 weeks in duration. They found effects were small to moderate for pain, limited for function. Rates of opioid dependence in primary care range from 3% to 26%, again, depending on the population that was being looked at and the methods and definitions for opioid dependence. A number of studies showed a dose-dependent association with risk for overdose and harms. At the same time, there is no evidence that dose escalations actually are associated with improved pain or function. There are no clear differences between round-the-clock and or long-acting opioids versus PRN and or immediate-release opioids. Some studies show that initiation with a long-acting opioid is associated with increased risk of overdose. Evidence suggests that methadone and using benzodiazepines plus opioids is associated with higher mortality and overdose risk. There are a number of risk assessment instruments out there, but their accuracy is inconsistent and appears to be suboptimal. And there is an increased likelihood of long-term use when opioids are used for acute pain. So several studies have looked at, for example, patients undergoing minor surgery, so things like varicose vein surgery or cataract surgery, etc. And if you get an opioid following surgery versus not getting an opioid, you're actually more likely to be on an opioid 1 year later. So how we use the opioids for these acute issues does seem to have some impact on long-term prescribing. The recommendations were grouped into 3 areas. The first was when to initiate or continue opioids for chronic pain. The next was opioid selection, dosage, duration, follow-up, and discontinuation. And then the last area was assessing and mitigating harms of opioid use. The recommendations were graded as Category A, or strong recommendation. These are ones that are generally felt to be applicable to most patients in most situations. Or B, recommendations, or conditional recommendations, where there is some more room for individualized decision-making. The supporting evidence was classified as 1, which is well-conducted RCTs, through 4, which is observational studies with limitations. Unfortunately, the vast majority of the evidence here is class 3 or 4. So the recommendations. The first recommendation is that non-pharmacologic therapy and non-opioid pharmacologic therapy are preferred for chronic pain. Consider opioid therapy only if the expected benefits are anticipated to outweigh the risk to the patients, and if you use opioids, to combine them with appropriate non-pharmacologic therapy and non-opioid pharmacologic therapy. Evidence suggests that a number of non-opioid therapies are effective for chronic pain. In a number of the studies, the benefits actually look similar to or only slightly less than opioids, and the risks appear to be substantially lower, right? Nobody's overdosed from too much CBT or too much, massage or whatever. We think that, there are a wide variety of these non-opioid therapies. We think that it makes sense to focus on more active therapies, so things like exercise or CBT that address the psychosocial contributors and that focus on movement and function. We know that these are really important in patients with pain. There are also other pharmacological therapies, things like NSAIDs, acetaminophen, anticonvulsants, SNRIs, that can be used in conjunction with non-pharmacological therapies. And again, it's actually surprising when you look at the data, the average benefits for these other non-opioid medications is not that much lower than opioids, and in some cases they're actually quite similar. So I think that the perception that opioids are highly effective for chronic pain is actually not strongly supported by the available data. When opioids are used, they should be combined with non-opioid therapies to provide greater benefits. Again, this is consistent with our biopsychosocial understanding of chronic pain, that just giving somebody a pain medication is not going to address these psychosocial factors that we know are so important in contributing to pain, and address psychological comorbidities, which are extremely common in people with pain. There are a number of CAM therapies, complementary and alternative medicine therapies, that have been evaluated for chronic pain. We led an ARC review on pharmacological and non-pharmacological therapies for low back pain that came out just last year. So this just summarizes some of the data that we found. Manipulation in our review was similar in effectiveness to exercise. Acupuncture is more effective than no acupuncture. The effectiveness versus sham acupuncture was a little bit more mixed. Massage was more effective than usual care, though I'd say the evidence was fairly limited. The quality of the studies left something to be desired. There was also a lot of heterogeneity in the massage techniques that were used. Yoga has been studied more recently in the last probably 6 or 7 years. Again, more effective than usual care or education, and appears to be similar in effectiveness to exercise. Tai Chi kind of is in kind of the same category. So a lot of these movement-based mind-body interventions, we have kind of growing evidence. Mindfulness-based stress reduction, there was a randomized controlled trial that just came out within the last year, which showed that it was similar in effectiveness to CBT and more effective than usual care. When we're confronted with this wide variety of interventions, it can be difficult for clinicians to know exactly what to do. I think one thing to keep in mind is that there is some evidence that the benefits of some of these therapies might vary based on patient expectations of benefit. So people who don't really think that acupuncture makes sense or is likely to be effective probably don't tend to respond as well to acupuncture. And the same is true probably true for manipulation and other interventions. We don't have good data yet on how use of these alternative therapies may impact opioid prescribing, so hopefully we'll have more evidence on that soon. In terms of patient selection and risk stratification, we think all patients should undergo risk assessment. We know that aberrant drug-related behaviors can occur in up to 50% of patients prescribed opioids for chronic non-cancer pain. The strongest predictor is a personal or family history of alcohol or drug abuse. Psychological comorbidities are also a factor. The risk stratification can help guide the management plan, including the decision of whether to initiate opioids and how you're going to manage and monitor the patient if you do initiate opioids. Only consider opioids in patients in whom benefits are likely to outweigh risks. What we're trying to hammer home is that opioids are not always appropriate. You need to use your risk assessment to help you, guide that decision, and it should be a really carefully thought out decision. As I mentioned before, we do have some tools for risk stratification, though the accuracy is not great. So this is a picture of, this is the Boston Marathon. I think this is the 1983 marathon. This is Alberto Salazar in the back, and this is a guy named Dick Beardsley in the front. I like to show this picture because I think it illustrates kind of some of the risk factors for opioid use disorder. So Dick Beardsley was he actually ended up losing this race. They were neck and neck. This is a very famous race. They call it the Duel in the Sun. It was very hot that day, and they basically were in lockstep the whole way, and Salazar pulled away at the end. Dick Beardsley, his father was an alcoholic, so he stayed away from alcohol his whole life. After his marathon days were over, he was in a pretty bad farming accident, and he was exposed to opioids, for his pain. And he has a book, and he writes in the book, he says, it felt like this is what I was missing my whole life. He became extremely addicted. He forged prescriptions. He was going across state lines. He was eventually caught by the DEA. They thought he was a dealer because the amounts he was getting was so high, but it was all for himself. And he eventually went to jail for it, and he speaks about this now. He goes around the country. But this kind of illustrates to me kind of the strong genetic component that people think about personal history, but they often forget about the genetic component, which is also very important for substance abuse, and we think accounts for about 50% of substance abuse. This is the opioid risk tool, so this is one of the tools that's often used in primary care settings now. As I said, these tools tend to work a lot better in their initial studies. So this is from the original data. This is from Lynn Webster in Utah. You can see if people score low, they have a low chance of subsequent misuse behaviors. And if they score high, over 8 points, it's over 90%. Simple point system. So even though, like I said, the data on the accuracy of this for prediction is suboptimal, I think it at least gets people to think about the factors in a more systematic way, even though I think you have to take the numbers with a little grain of salt. And this has started becoming incorporated into a lot of EMRs and things like that. The second recommendation is before starting opioid therapy, establish treatment goals, including realistic goals for pain and function, have a plan for discontinuation if benefits do not outweigh risks, only continue opioids if there's clinically meaningful and important in pain and function that outweigh risk to patient safety. So before initiating opioid therapy, be explicit about expected benefits, determine how the effectiveness will be evaluated, and establish realistic treatment goals. And we're trying to get away from people focusing solely on pain. I think this has been one of our problems, that we know that the average pain relief is only going to be 1 or 2 points with opioids. Very few patients have their pain completely relieved with opioids. So if that's your goal, is to get pain relief, you're just going to be chasing that and titrating up the doses, etc. Pain and function are actually not completely connected. People's function can be quite different at the same level of pain, and we actually can show that in people undergoing interdisciplinary rehab, for example, their function can improve quite a bit even when their pain scores stay relatively simple. We want to get away from the idea that someone saying that their pain score has dropped from an 8 to a 6 means that they're a whole lot better when you talk to them and they say that they're not working, they're not engaging with their family and friends, they're not enjoying life. If you actually talk to people with chronic pain, people think that, I think the perception is that what people want is to have their pain go away, and I think that's part of it. But if you actually ask them, what they really want, a lot of people will say, I want my life back. And I think that's a very different kind of statement. That's a functional statement. They want to be able to do, the things that they enjoyed doing before. And so I think we're trying to get away from the pain as the sole goal and looking much more at function. PEG is one of the scales that we can use. This is derived from the Brief Pain Inventory. Aaron Krebs in Minnesota is the one who developed this. It's a simple 3-item measure. Again, a lot of people are starting to try to incorporate this into their EMRs. I think it's a quick way to assess both pain and how it's impacting function. The third recommendation, before starting and periodically during opioid therapy, discuss known risks and benefits of opioid therapy and responsibilities for managing therapy. We want patients to be aware of the harms of opioids, including serious as well as common adverse effects, and issues with increased risks of overdose, including increased risk with higher doses and when using opioids with other drugs or alcohol. Patients should be aware of the need for periodic reassessment, PDMP and urine checks, as well as risk to family members and individuals in the community if the opioids aren't secured properly. The fourth recommendation, when starting opioids, prescribe immediate release opioids instead of extended release or long-acting opioids. This sounds like this should be pretty common sense, but there was a recent VA study that showed that a surprisingly high proportion of patients who are opioid naive are started on long-acting opioids, and they had a higher risk of overdose. So initiate therapy with short-acting opioids. The CDC recommends caution with use of methadone. In general, it should not be a first-line extended release or long-acting opioids. It was actually used quite a bit for this at one time, really because it was cheap. But there was very little data showing either safety or effectiveness for chronic pain specifically. And we have data showing that methadone accounts for a very large, a disproportionate number of the overdose deaths. Methadone prescribing is somewhere around 8 to 10% of opioid prescribing, but it accounts for something like 30 to 40% of opioid-related deaths. If you do use methadone, you need to be familiar with its unique risks and be prepared to educate patients and closely monitor them. The issues with methadone include the long and unpredictable half-life, the QTC prolongation, which can lead to arrhythmias, and increased incomplete cross-tolerance, which can make it difficult to switch from other opioids to methadone. The CDC also recommends caution with transdermal fentanyl, which has more complicated dosing and absorption properties than most oral opioids, and again, be prepared to educate patients about its use. This just illustrates the half-life issue with methadone. So this is just kind of basic pharmacology. It takes about 3.5 to 4 half-lives to reach steady state. If you have a half-life of 30 hours, that's going to be close to a week. If you have a half-life of 60 hours, which can occur in some patients with methadone, it's something like 10 to 12 days. So that's the levels of the drug continue to accumulate. If patients or clinicians are taking extra doses or increasing their doses before they reach that steady state, that drug level just continues to go up. And that's when people suddenly stop breathing and don't wake up. And this slide shows an example of a prolonged QTC interval degenerating into torsades in a patient on methadone. So that can turn into ventricular. Torsades can be a perfusing rhythm, but you still don't want to have it, and it can turn into a non-perfusing, V-fib arrest, etc. The fifth recommendation, when opioids are started, prescribe the lowest effective dose. Use caution when prescribing at any dose. Reassess when you increase the dose to over 50 morphine milliequivalents per day, and avoid increasing to over 90 morphine milliequivalents per day. Over the last 5 or 6 years, we've had a number of large observational studies, most of them fairly well done, that have looked at the relationship between opioid doses and risk of overdose. What you see is that at even 20 to 50 morphine milliequivalents, you start to see some increase in dose, so something like 1.3 to 1.8 in terms of the odds ratios. By the time you hit 50 to 100, the risk is increased 2 to 5-fold, and by the time you hit over 100, it continues to go up, and in some studies, the risk of overdose is 7 to 9-fold. Most of these studies are based on administrative databases. They did try to control for potential confounders, so other medications that were used, other diagnoses, etc. So in terms of dose considerations, the recommendation is to start at low doses, increase gradually by the smallest practical amount. But you don't need to be on high doses to overdose. In a VA study, the average dose in overdoses was 98 morphine milliequivalents per day, which I think is lower than many people would think. And about 50% of the overdoses occurred in patients on less than 60 morphine milliequivalents per day. So people ask where those 50 and 90 numbers come from, and some of it is based on this kind of data. If the total opioid dose reaches 50 morphine milliequivalents per day, clinicians should reassess pain, function, and treatment, increase the frequency of follow-up, and consider providing naloxone. The naloxone is to be used by family members and friends who witness a potential overdose event and can be life-saving. Avoid increasing opioid dosages to over 90 morphine milliequivalents per day. Only consider doing this in patients who demonstrate continued incremental benefits relative to harms. I think this is actually relatively uncommon, at least in my patient population, and I don't remember the last person that I've titrated above 90. I do have a lot of people that are that have been on higher doses, but they've been on that for a long time before we really understood these dose-response relationships. When escalating dosage requirements, discuss other pain therapies with the patient, consider working with the patient to taper opioids down or off, and consider consultation if you need additional expertise. This has been a major issue, I think, in clinical practice. Patients that I just mentioned who are already on a high dose, either from you or that are coming to you from another provider. Many of these patients meet criteria for tapering, and I think in those situations, what to do is pretty clear. If they're not experiencing benefit, if they're having important adverse events, if they're exhibiting, worrisome behaviors. All of those are clear indications for tapering, and I think we should be doing that. I think the harder people are people who, don't have clear indications for tapering. They may or may not be doing a little bit better with the opioids, and it's difficult because they're physically dependent on the opioids, and they're going to have some withdrawal and all these other issues. In these patients, we recommend at least discussing the recent evidence regarding dose-dependent overdose risks and offering the opportunity to reevaluate continued high use. I'm pretty routinely trying to taper my patients in this situation. I'll tell them that we won't know how they're doing until we give it a try. Many of the patients actually do fairly well. Their pain isn't better when we taper them, but it also isn't worse, and some of them feel like their side effects are better. And I'll use the analogy of kind of going down the highway that because a lot of them will say, well, I haven't had a problem yet, why do I need to taper? And I'll say, well, it's like driving down the highway at 150 miles an hour. Just because you haven't had an accident yet doesn't mean you're not going to. So we need to get the speed down a little bit to the degree that we can. And so I'll work with my patients to do this. It is quite challenging in clinical practice. The sixth recommendation, when used for acute pain, prescribe the lowest effective dose of immediate release opioids and prescribe no greater quantity than needed for the expected duration of pain, severe enough to require opioids. Usually 3 or fewer days will be sufficient. You may need up to 7 days. Again, we're trying to get away from the practice of, people getting, 50 pills of hydrocodone for, a tooth extraction or whatever, which I think has been pretty common practice and has led to a lot of unused opioids sitting in people's medicine cabinets. If people do continue to have pain longer than expected, they require reevaluation, and don't use extended release or long-acting opioids for acute pain treatment. Seventh recommendation is evaluate benefits and harms within 1 to 4 weeks of starting opioids, or when dose escalations occur. Reevaluate benefits and harms every 3 months or more frequently. And if the benefits don't outweigh the harms, clinicians should optimize other therapies and work with patients to taper opioids or to taper and discontinue. So this is something we would do with pretty much every other drug, right? If somebody's blood pressure isn't improving on a certain blood pressure medication, we're not going to just continue it indefinitely. We're going to try to get them off that and put them on something else. But with opioids, too often that hasn't been the practice. At follow-up, we need to determine whether the opioids are continuing to meet treatment goals, whether there are common or serious adverse events or early warning signs, whether the benefits continue to outweigh risks, and whether the opioid dose can be reduced or the opioids can be discontinued. Tapering is a major challenge in clinical practice. Many primary care docs are very uncomfortable with this. They have not received a lot of training in this, and they don't feel like they have the support and resources to do this. But it's an important skill that I think we're trying to teach clinicians to be able to do. They need to be able to, so we recommend that clinicians work with patients to taper when they're not having clinically meaningful improvements in pain or function, when the doses are over 50 morphine milliequivalents per day without evidence of benefits, if they're on a concurrent benzodiazepine that can't be tapered off, when patients request dose reductions or discontinuation, and if they've had an overdose, other serious adverse event, or warning signs. There was a recent study showing that the majority of patients who had an overdose event on opioids were just put right back on their previous dose of opioids, which probably isn't the best practice. We want to taper slowly enough to minimize opioid withdrawal. So again, this is a physical phenomenon, and we need to recognize it and try to minimize it for patients. The guideline says that a decrease of 10% per week is a reasonable starting point. Just from kind of clinical experience, many patients require slower tapers than that. And, you know, it can be months to years even. Again, I think if you're getting this, you know, the analogy again is if you're getting the speed down, I think it's okay if it takes some time to do it as long as you're making progress. And again, this is kind of what we're seeing in primary care settings. We need to optimize non-opioid pain management and psychosocial support while we're doing this. So the idea isn't to just take off the opioids and not do anything to, you know, manage the pain. We need to try to optimize other non-opioid therapies while we're doing this. The eighth recommendation is, you know, before starting and periodically during continuation of opioid therapy, evaluate risk factors for opioid-related harms. Incorporate strategies to mitigate risks. This includes naloxone in patients that have risk factors for opioid overdose. So this includes a history of overdose, history of substance use disorder, being on a higher dose, concurrent benzodiazepine use. The next recommendation is to review the patient's history of controlled substance prescriptions using state PDMP data. This means monitoring when you start therapy as well as periodically during opioid therapy, ranging from every prescription to every 3 months. And the PDMP, as you guys know, it's rather fragmented at this time, so it's state by state. And some states have more functionality than others. The requirements in terms of logging in and passwords and all those kinds of things can be a little bit onerous. I think a number of states are trying to make this easier. In Oregon, for example, there's a law that's being considered now that's going to allow PDMP information to be pulled into the EMR so that it can be, instead of having to log in separately each time. And also in Oregon, we had a law passed recently that allowed non-physicians, so medical assistants, et cetera, to access PDMP data before it had to be a physician or a pharmacist. And so we're trying to make this easier. We still run into issues like Portland, for example, is right across the river from Washington State. So, you know, you have to access the Washington State PDMP if your patient is getting opioids there. Most Oregon physicians don't have access to that PDMP. If you're in the VA, we don't have access to that. I mean, there's all sorts of issues with this, and I think hopefully at some point we'll have some national PDMP system, but at this point it's still state by state, and it does provide some useful information about where patients are getting opioids and other controlled substances. If you do see patients receiving prescriptions from multiple sources, on high doses or dangerous combinations, it's important to discuss the safety concerns with the patient as well as with other prescribers that are involved. Consider tapering to a safer dose, and again, naloxone. Evaluate for opioid use disorder and discuss those concerns with your patient. And again, this isn't about catching patients doing, you know, something bad. It's about identifying risky behaviors and providing interventions that may be life-saving because of these risks. The 10th recommendation is obtain urine drug testing before starting opioid therapy and consider testing at least annually to assess for prescribed medications as well as other controlled prescription drugs and illicit drugs. Urine drug tests can be tricky. Clinicians need to be familiar with urine drug testing panels and how to interpret those results. Understanding the metabolic pathways, like I talked about before, can be quite helpful. So for example, the synthetic opioids are on their own pathway. You shouldn't get any of the morphine-like metabolites in somebody prescribed methadone, for example. And so just understanding some of those basics about which are the synthetics, semi-synthetic, and synthetic opioids can help you kind of think through some of this stuff. Before ordering urine drug testing, explain to patients that testing is intended to improve their safety. Again, this isn't punitive or trying to catch people. I don't think that should be the framework that we're looking at. It's really to try to identify things that put patients at risk and to improve, you know, safety of prescribing. We need to tell patients what the expected results are and ask patients whether there might be unexpected results, and sometimes you'll hear surprising stuff. Discuss unexpected results with the local lab and the patients. Verify unexpected, unexplained results using a specific drug test. And again, this isn't, we shouldn't be using these to kick people out of practice or whatever. These are opportunities to identify risky practices and risky behaviors that we can do something about. The 11th recommendation is to avoid prescribing opioids and benzodiazepines concurrently whenever possible. Benzodiazepines by themselves are not associated, don't seem to be associated with a particularly high overdose risk, but when used together with opioids, that combination appears to be associated with additive or synergistic risks. We see a very high proportion of opioid-related overdose deaths have benzodiazepines on boards. Other medications with respiratory depressant effects may also be associated with similar risks. Benzodiazepines are similar to alcohol in how they work in terms of withdrawal, etc. So benzodiazepines do need to be tapered gradually. You need to be aware of, these sympathetic effects and, risk for complicated withdrawal. There are other evidence-based psychotherapies for anxiety. Benzodiazepines are really not a recommended treatment for pretty much anything, at least as a first-line treatment. We have better treatments for the issues that most people are prescribed these medications for. These include CBT, antidepressants that are used for anxiety, and other non-benzodiazepine medications. And sometimes we may need to coordinate our care with mental health professionals. The last recommendation is to offer or arrange evidence-based treatment. This usually means medication-assisted treatment with buprenorphine or methadone in combination with behavioral therapies for patients with opioid use disorder. Opioid use disorder, as we showed you the slide before, has become increasingly prevalent with increased use of opioid medications. This is a potentially life-threatening health condition. If you suspect opioid use disorder, discuss it with your patient and provide an opportunity to disclose concern. We have DSM-5 criteria for opioid use disorder now. If it's present, patients should be offered or arranged medication-assisted treatment. This could be buprenorphine through an office-based buprenorphine treatment provider or an opioid treatment program specialist. It could be methadone maintenance therapy from an opioid treatment program. There is also long-acting injectable naltrexone. This can be used in highly motivated non-pregnant adults. Oral naltrexone is available, but I don't think has been highly effective, at least in most primary care settings. Primary care docs, so people, if you're not treating in a licensed opioid treatment program, office-based buprenorphine, you need to get a waiver. There's free training available from SAMHSA, so that's just a link there. I think this is something that we really encourage people to consider doing this. This is treating opioid use disorder can actually be quite rewarding, and it's, like I said, it can be one of the really things that can have an impact towards preventing unnecessary deaths and other adverse events. So this slide just kind of summarizes some of the things that we think can be done to mitigate risks associated with use of opioids. So, the guideline isn't about saying we can't use opioids in any patients. We want clinicians to be more careful about considering who they're going to use the opioids in, be better about using non-opioid therapies that are indicated, and then if you do use opioids, we want them to prescribe them in a way that's safer. So this includes using lower doses, not initiating therapy with long-acting opioids, more frequent follow-up, right? So the period after initiating opioids is actually a higher risk period, so we want patients to be seen in those first 1 to 4 weeks. Monitoring, including urine drug testing and PDMP monitoring, avoiding sedative hypnotics, especially benzos, diagnosing and treating opioid use disorder, consulting with your colleagues in addiction, pain, and psychiatry when needed, doing more frequent refills with smaller quantities in people who are at higher risks. Abuse deterrent formulations may have some impact on people who may engage in very high-risk behaviors, and then naloxone, as we've mentioned before. So in conclusion, The data on the long-term benefits of opioids is sparse. Opioids may have little effect or even worsen functional outcomes. We have increasing evidence regarding the dose-dependent risks of opioids with limited evidence on the benefits of higher doses. No opioid is safe. There was a time when sustained-release oxycodone was touted as being safer than other opioids, which has not turned out to be the case. I like to remind people that heroin was actually originally developed as a safer alternative to morphine and was marketed as a cough suppressant in kids at one time. So we've looked for safe opioids for a long time, and so far none has kind of fit the bill. So we need to treat these medications with respect. Don't think that these abuse deterrent formulations are going to fix the problem. They aren't, people can still overdose on an abuse deterrent opioid. The available evidence suggests that the potential benefits of opioids are at best finely balanced with the harms. I think this supports the approach in the CDC guideline. This means more selective and cautious prescribing of opioids, particularly with higher doses, using non-opioid treatments for chronic pain, particularly those that address psychosocial factors. I think it makes sense to prioritize these more active therapies like exercise, CBT, mindfulness-based stress reduction, etc., versus some of the less active therapies, things like acupuncture or massage, where somebody's just kind of receiving something and they're not really addressing kind of psychosocial issues or trying to improve their function. Avoid higher doses, assess risk as part of standard practice, routinely integrate the risk mitigation strategies that we talked about, identify and avoid high-risk prescribing practices. Don't just focus on pain. Really, the focus should be on improving function. And I think one of the kind of underlying issues that I at least want to mention here is that we recognize that really there needs to be policy and system changes to be able to facilitate a lot of the things that we're recommending in this guideline. It can be very difficult to get the kinds of therapies that we think are maybe more effective for patients. So there clearly needs to be some policy and implementation research to be able to deliver the kind of care that we think is optimal. So this just is some of the references to the CDC guideline. There's a slide set. I borrowed some of the slides for this presentation. And then there's a number of fact sheets, checklists, dose calculators that the CDC has developed as well. And that's our summer vacation. That's one of my kids. That's in the Bugaboos in Canada. So pretty spectacular area. So that's the last slide. So I think we have a little time for questions.
Well, Roger, that was really terrific, and these guidelines have had enormous impact. So I'm sure we have questions and comments. This is Dr. Bushnell, who is our scientific director.
Thank you very much. I've been interested in these guidelines, and one thing is in your articles, you show these big tables that you obviously didn't show here, but the strength of the evidence. So basically, you're saying the evidence, the evidence is very weak for the efficacy of opioids for chronic pain conditions. So then why in the guidelines do they say, okay, but if you're going to do it anyway, then you do all this other stuff? And if it's not, either there should be more studies to know if that, in fact, there is any efficacy, or I don't understand having so many guidelines about what to do if you decide to go ahead and prescribe for chronic pain, right, even though we shouldn't prescribe for chronic pain.
No, it's tough, and we actually yes, it's true that almost all of the data, or the vast majority of the data on opioids for chronic pain is very short-term studies, and this is because those are the studies necessary to get regulatory approval for these drugs. Once these drugs are on the market, there's very little incentive for people to do more studies. And so this is a huge gap. And I think we've tried to highlight that repeatedly, that we really don't have good data to understand long-term effects. We actually know that even at short term, the effects aren't all that big. And it's hard to believe, knowing everything we know about tolerance and physical dependence, that they'd be much bigger long term. But again, we don't have good data there. I think the reality is that opioids are still kind of considered the, most effective medication for analgesia. We know at least for acute pain they are. they're approved for chronic pain by the FDA, so there are regulatory groups that have approved these treatments, and they're going to be used in clinical practice. And I think our approach was to try to help people, if they are going to use them more safely. I think we tried to do our best to kind of discourage kind of haphazard use of these medications, and for people to be a lot more judicious about how, who they're prescribing to and how they do it. I think it would have been very difficult to produce a guideline that says you can't use opioids for chronic pain. I mean, I think with, the process that we had with the stakeholders and experts involved, many more studies need to be done. Yeah, no, I agree, but I think, like I said, I think we're trying to kind of bend the curve down without kind of blowing things up, which would be, it was a challenge getting this guideline out, to begin with. So there's a whole backstory there, but just getting out what we did was a huge effort.
And it has in fact been quite controversial. So I think you really managed to find that midpoint. We have more questions. Craig, Dr. Hopp?
So a plant known as kratom has been much in the news recently as an alternative, supposedly, for opioids. I was wondering, in your practice, how prevalent is the use of that plant? Because given the feedback that DEA apparently got, it's more prevalent than I expected it to be.
Yeah, so I actually don't know. None of my patients have told me they're using that. I haven't asked explicitly about that. My understanding is it's quite variable, from region to region. I understand that it's very available in, these head shops or whatever you can go to and buy, little packets of this stuff or, capsules of this stuff. But I think even the FDA's data suggested that it's quite variable, that there are some places where it's being used more than others. And I think kratom, the evidence is really lacking at this point. It's thought to have some opioid-like properties, which makes me worried that if it has opioid-like properties, why wouldn't it have some of the opioid-like, problems in terms of abuse and addiction, etc. And we just don't know a whole lot about it. And we know that the way it's being dispensed and sold right now is that there's literally no oversight of this stuff. So who knows what people are actually getting. So I think there are a number of issues out there. I think this is one of the challenges that the DEA and other groups face when these new substances start to, it's just the science just isn't there yet. And so kind of knowing what to do from a public policy standpoint is very challenging. But I haven't seen it a lot in Oregon. I mean, we have legalized, marijuana, so, maybe people are doing that instead of kratom. I don't know. But it's, like I said, I think it's quite variable right now.
Yes, go ahead.
Alicia Hogenmiller, Georgetown Medical Center. So what has the initial feedback been, both good and bad, from clinicians, patients, and opioid manufacturers about the guidelines?
It's interesting because before the guideline came out, there was a lot of debate and feedback. I mean, the guideline was put up for public comment. I think we got over 5,000 comments, right? I do some guidelines where we get like 10 comments. So this is obviously of a lot of interest. It seemed like once the guideline came out that a lot of that dissipated and it became more like this is kind of the way it's going to be, and people are spending a lot more time actually trying to implement the guideline than to try to fight it at this point. That's been my impression, at least. There are still, I do a lot of talks like this in different, groups, and some are more, hostile than others. There are definitely clinicians that feel that the guidelines are too prescriptive, that they say that we can't prescribe more than 90 morphine milliequivalents and all those kinds of things. But if you actually read the guideline, that's not what it says. It says avoid prescribing over 90, and if you do prescribe over 90, these are the kind of, things that you need to meet. So I think the top line statements may sound more prescriptive than the actual text reads. I think that, we do also make the statements that, they're not meant to replace clinical judgment and all the kind of other caveats there. So I think from that standpoint, we do get that feedback, and patients are the same. I mean, a lot of patients are upset. They feel like, I think clinicians like it because they can blame the guideline instead of saying it's them doing it. But patients are also upset, and understandably, they're suffering and they have a lot of pain. But I have patients, I'm a primary care doc. I deal with this every time I'm in clinic. And I spend a lot of time explaining to my patients what I'm trying to do, and that it's all about safety. It's not about trying to take away their opioids and not treating their pain. And I think you can have those conversations and you can get better at it over time. So, there has been a lot of pushback. I think the pharma response has been interesting. I've actually been approached by some pharma folks who say they really want to help solve the problem. And then others, they're probably doing stuff behind the scenes that I don't know about, because this is still a big, business. So anyways, and I think from the payer perspective, a lot of state agencies and payers are really behind it. I think the recognition of the public health implications and problems have just become so widespread at this point that this is giving it a big push.
Hi, my name is Dave Scalzi, and if I may, I'd like to answer that first question from the other side of the physician's desk. This is a thought that is sort of below the purview of what you've been speaking about. We need guidelines because pain is one of the most difficult things to treat. There are so many factors involved in pain. And even in people like myself, I have chronic kidney stones. I've been dealing with it for 20 years. Morphine is still the safest, most effective thing that's out there because no one is doing studies, basic studies, on a lot of the things that cause pain. So I think guidelines are a good idea, just as long as we remember not to throw out the baby with the bath. But that's just from the other side, as I say, of the physician's desk.
Thank you.
Thank you.
We are at 11, which was our original scheduled stopping point, but obviously this is an interesting conversation that a number of us would like to keep going. So I understand both the room and Dr. Chou are available. We're going to extend the Q&A for another 20 minutes for people who want to stay. People who have other commitments, feel free to keep moving. Dr. Iadaroa.
Thanks. From the Clinical Center. So the healthcare system is a large enterprise with many interlocking organizations. And one of the complaints at the last American Pain Society town hall meeting was that physicians that want to employ cognitive behavioral therapies don't get reimbursed for that. So this is something that could be addressed, but certainly above the, or on a different portion of the food chain from the NIH and other organizations in the government could probably do a much better job of that. And this guy was from Mississippi, and they were funded by the state and operated at a loss. And he said, if I was in private practice, I could never, offer the treatment that we offer here.
Was he trying to do it himself, or did he have?
I think he had a sort of
group,
a state practice, a health, a small sort of.
Yeah.
I don't know exactly. I can't say.
Yeah. So there's been a lot of issues about how to provide this care, and we were talking about this a little bit beforehand. That a lot of the non-opioid therapies that we recommend. In my practice, it's very hard to get CBT because many providers don't take the insurances that my patients have, or if they do, they're busy. They're too full and they can't, they're not accepting new patients, etc. And the other issue that complicates is that I often am not sure what they're doing, it's hard for me to know how good of a CBT this is a very individual, it's not like giving somebody a drug where you can just give the dose and you know basically what somebody's getting. When you send somebody to a psychologist for CBT, it's very dependent on, the skill of that person. Mm-hmm. So there are those challenges, and we've also had the reimbursement challenge in our state. I'll tell you, for it's pretty interesting in Oregon, the Oregon Health Plan, which is our expansion of Medicaid, right? And the way we expanded Medicaid was we designated which conditions would be covered and which weren't. For a long time, low back pain was not covered. And this was very difficult for us clinicians because basically we could give people NSAIDs and maybe an opioid. We could, they let that kind of slide by, but we couldn't get somebody even PT. They actually just changed that recently so that low back pain is now above the line, so it's covered. And they're explicitly encouraging all sorts of non-opioid therapies. So they say they're going to cover, this is for Medicaid patients, they're going to cover CBT, manipulation, massage, all these kinds of things. And they've basically said that we've kind of run through some of our numbers and we think this is actually going to be a cost savings thing in the long run, even though, it looks like it's more expensive up front. And so I think this is the kind of thing that may, hopefully this type of thinking is going to start to push things in that direction. I think the accountable care organizations and kind of bundled payments and things like that will make it easier to provide these kinds of services. I think that some of these can be integrated into primary care, settings. Right now, people aren't reimbursed appropriately for it, but primary care docs can do a lot of these techniques, these mindfulness techniques and motivational intervention. It wouldn't be hard for people to get some basic training in some of these things, and I think ideally it could be integrated into those things. So I think a lot of stuff needs to happen, and I think we're fully cognizant of that. But I do see some movement in that area and some recognition that, that these systems changes do need to take place.
One more short one.
Yeah.
So there's a lot of work now focused, this is completely on the other side of the spectrum, focused on generating biased agonists. And I know that the Trevena compound went through phase 3, and recently there was a large paper in Nature on PZM21 and its discovery and development. And I'm wondering if you've had a chance to review the data from the Trevena compound or used it, and if you could comment on whether these new developments, do you have a feel for whether they're going to improve the situation or not, or just sort of keep it about the same?
Yeah, I haven't looked at, we focus on kind of clinical outcome stuff, so none of that stuff is kind of at that point yet. And there has been stuff going on, kind of trying to find the next, opioid, the next non-opioid analgesic, and people have talked about endogenous opioids and things like that for a while. And I've actually read stuff saying that they think that these endogenous opioids won't be addicting, which puzzles me because if they're, I don't know why just being an endogenous opioid would make something not be addicting. So, from my standpoint, at least from an evidence synthesis kind of standpoint, we need to see the data. I think it's way too early to know. Like I said at the end of my talk, I think that we've had hopes before that, we'd come up with a safe, opioid potent, medication, and it just hasn't happened yet. So I'm a little, until we see the data, I'm just, I'm not going to hang my hat on it yet.
I would have to agree. Thank you.
The runner's high is an example of a potential addictive endogenous opioids, maybe. Here's one more question, and then I think we'll do a little more informal conversation outside. But I'll take one more question here from the mic.
This is related to his second question. I wanted to ask if there were examples of non-opioid pharmacologic treatments for chronic pain. I know I've heard of ketamine is a pretty up-and-coming area of research, and I wanted to ask if you knew anything about that or similar treatments that have been used.
Yeah, ketamine has been around for quite a while, actually. It kind of went out of favor because it has a lot of what we call dissociative effects, so people can, feel like they're out of their body, and that kind of people describe weird experiences with it. We actually suggest ketamine as one of the strategies to use for management of perioperative pain in our, post-operative pain guideline that came out a year or two ago, as well as, other things like gabapentin, pregabalin, using NSAIDs. Multimodal therapy was kind of the way to go. I think that there are risks with ketamine also. I understand it can be obtained on the street and people abuse it. So it's not a, non-abusable drug or whatever. I'm not sure that people have the same risk of overdose that you do, like you do with, the respiratory depression overdose risk that you do with opioids, but you certainly can have, it's a psychoactive drug. It can cause, those kinds of effects as well. But I think, again, to me, I mean, there's a huge evidence gap. We don't have good data yet to help us understand how replacing opioids or using these other drugs, impacts opioid use, and then the stuff that we really care about in the end, which is overdose risk and risk of opioid use disorder and things like that. We need a lot, one of the things I've always said is, these guidelines come out and we need to understand what the effects are on patients. That to me is really key, and we think we're doing good, but we don't know for sure until we actually study it. So hopefully we'll get more of this data. We'll be able to learn what some of these alternatives. There are a number of groups like PCORI and other agencies that are trying to fund research to look for alternatives to opioids and things that can kind of new strategies to treat chronic pain. So hopefully in the next few years we'll start to see some of this out there. But at this point it's very sparse to know what the optimal non-opioid strategies are.
Thank you.
Was there I understand there's a Facebook question. Do you want to introduce that, Yasmin?
Sure. So we've been streaming this lecture live on Facebook, and people have been writing in, and we got one question, or a series of questions that kind of all go together. And this person writes, what is the feedback from chronic pain patients? If there are not studies on the long-term effects, how can you make assumptions on the efficacy? How can we get these studies implemented to help those in chronic pain? What is being done to change the policy approvals of insurers so other modalities can be utilized with patients in pain?
Big question.
Yeah, it's a big question. And like I said, I think patients understandably are concerned about being cut off or being taken off of a medication that they think is helping them. Like I said, we have very little data on effectiveness and safety long term, but we have clear evidence on very serious harms. I mean, there's no other drug that I know of that is associated with this many deaths, and really there's no other drug that would be approved that had, if we knew that it would cause, this many problems. So I think we have to act on the safety side. At the same time, we need to, acknowledge that that chronic pain is, a really terrible burden on patients, and we need to do what we can to treat it. And in some cases, that may mean opioids. But if we do use them, what the guideline is trying to get people to do is to use them smarter, to use them more safely. And, like I said, hopefully we'll have more data on effectiveness at some point. But it's very unlikely, like I said, that based on what we know about physical dependence and tolerance and all that the long-term effects of opioids are likely to be much bigger than we see short-term. And short-term, they're not very big for chronic pain. Chronic pain is just a very different animal from acute pain. We know we can relieve, 90% of acute pain with opioids. With chronic pain, even short-term, we're lucky to get 20% pain relief. And so that's what the data tells us.
Well, this is an incredibly important topic and just a beautiful lecture that covers a broad range of issues. So thank you. I'm sure we could keep going with questions for many hours, but at this point we'll move outside and continue the conversation. And then, so thank you very much, Roger.